Um, Hello, everyone, and welcome to Manama Health Conference and Expo 2023. I would like to start by thanking the organizing committee for inviting me to participate in this prestigious event. And my presentation is about the use of artificial intelligence in image analysis in radiology. Let me start by highlighting a fact. That we all have been using artificial intelligence in our daily activities subconsciously without paying attention. As a simple example, on my way here to Manama, I used artificial intelligence in booking my airline tickets, identifying possible hotels to stay in, Manama attractions to visit. Upon arrival, I sent text messages to families and friends. I used artificial intelligence to navigate my way through the beautiful roads and streets of Manama here to the conference. So we've been all using these AI technology and softwares, even though we never paid attention. Even in our medical practice, we certainly use it daily in getting a prelim interpretation of ECG studies, highlighting abnormal findings in lab results, making our dictations through voice recognition systems, and monitoring patients and our own daily activities and vital signs. These are all artificial intelligence software that are available for use by public and by professionals. And this is not new even in the field of radiology. These are two articles by the same author dating back to 1955 and 1987, talking about computer-aided diagnosis in radiology and the use of computers in image interpretation. But why radiology? Why radiology is an area of interest for artificial intelligence to come in with such speed? Well, part of the blame is on us as radiologists. We've been digitizing images by using computer radiography and digital radiography systems, and by making them available on PACS and radiology information systems for more than a decade, almost 2 decades. So the data is available in digital format for computers to analyze, understand, study, and then interpret. Not only this, but computers systems have an advantage of being able to look into the raw data that is available at a pixel level that is beyond the capability of the human eye. Another factor is the proliferation of medical data. It used to take 3.5 years to double medical data in 2010. Now it's almost 3 months to double medical data. There are more than 800,000 medical articles being published per year. Similarly, diagnostic errors that may affect patient life and even result in mortality were estimated to go up to 10%. That mounts up to almost 350,000 mortality per year in Europe and about 40 million globally. The other factor is some of the radiology and radiography work is rather repetitive, such as patient positioning, detection of anatomic landmarks, measurements of lesions, correlation with previous images. These are repetitive routine work that is being done by the radiographers and the radiologists. And that makes it easier for artificial intelligence and computer software to imitate and learn. There is certainly global shortage of radiologists, which gives a space for extra pairs of eyes and hands to come in. The speed and the efficiency of computer systems in doing these procedures is much faster and more efficient than human capability. And the quantitative image analysis done by artificial intelligence provide more precise and consistent data, particularly when you're talking about tracking the size and the changes of morphology and measurements of a particular lesion over time. If we're talking about the field of radiography, certainly image quality and identification of emergency findings have place for artificial intelligence implementation. In image quality, assessing the collimation, rotation, the degree of inspiration or expiration, the cut-off of anatomic landmarks, the under and overexposure of the film, all leads to better collimation and better image quality. Similarly, highlighting important findings in emergency situations, such as the positions of tubes and lines and the presence of subtle pneumothorax or pleural effusion, is important. These things have resulted in improved image collimation and decreased patient exposure and enhanced departmental performance. It also leads to a better feedback to the technologist who can monitor his or her performance and audit the quality of the images that he or she is producing with the aid of the artificial intelligence softwares. In fluoroscopy, obviously, by lowering the frame and pulse rate, by keeping the height of the X-ray detector low to close to the patient's body, by limiting the use of the magnification, as well as by identifying the anatomic area of interest and proper collimation, all improve image quality and reduce patient radiation exposure. When you're talking about CT, the use of the ceiling-mounted 3D cameras in detecting the body contour of the patient to identify the proper central position of the patient in the gantry, and then the automation of the patient positioning, as well as detecting the incorrect patient positioning, all lead to reduced scan time, improve image quality, and minimizing radiation exposure. Similarly, artificial intelligence help in identifying the area of interest in the scout and selecting the proper protocol, the amount of contrast, the injection rate, as well as the protocol that is being used for the bolus chasing in terms of contrast injection in a dynamic CT scanning. All this results in better image quality and reduced radiation dose. And similarly, technically, it also can predict any errors that are anticipated in the machine and any unexpected machine downtime, so that it gives a pre-hand warning to prevent interruption of patient's flow and management within the department. Similar thing can be said about the radiographic part of MRI in terms of eliminating operator-to-operator radiation, particularly in terms of patient positioning, isocentering, and protocoling, the proper selection of the coil, the sequence, the scan parameters. All this improve the image quality, reduce the noise, and improve the signal-to-noise ratio, and get rid of and eliminate any unnecessary artifacts. All this improves image quality as well as improve the scanning time and reduce the patient waiting list. If we move into image interpretation, there are so many articles published in this field. I'm just going to highlight a few of them and leave the references for you to read and go into the depth of this information. For nodule detection, detection rate for actionable lung nodule on chest radiograph was higher when aided by artificial intelligence, almost doubled by use of artificial intelligence. Similarly, in lung cancer, artificial intelligence image analysis improved lung cancer detection. The sensitivity and specificity of artificial intelligence algorithms in finding malignant tumor nodule was 94% and 83% respectively. Moving into breast imaging, it certainly can help detecting breast cancer lesion, particularly in dense breast parenchyma. When radiologists were aided with artificial intelligence, accuracy increased by 9.5%. up to 84% accuracy in detecting lesions, small lesions in dense breast parenchyma. Similarly, predicting the occurrence of breast cancer by identifying subtle, however, suspicious lesions that may skip the eyes of the radiologist, particularly in a heavy load practice where you are bombarded with large number of mammographic images that you have to screen. Detection of such lesions would be almost impossible, and this is a 4-year later follow-up identifying a lesion that was present previously. In the field of emergency radiology and during on-calls, particularly where the first liners are the junior radiologists, artificial intelligence can help in identifying alarming findings such as intracranial hemorrhage, and stratifying the location of the hemorrhage, whether it is subarachnoid, whether it is parenchymal contusion, whether it is subdural, subsequently help in stratifying the patient's management and proceeding with accurate patient treatment. During on-call, pulmonary embolism is a major issue, particularly when the first liners are junior radiologists with limited experience. Then using artificial intelligence in identifying filling defects in proximal or distal branches of the pulmonary arteries is of utmost importance. And this was found to be a major area of implementation in artificial intelligence. Now, the utilization of contrast with the ever-ending saga of the complications of gadolinium-based contrast with potential deposition of the gadolinium in the human body. We always want to minimize the dose of contrast being injected. These are 3 images with 1/4 of the dose of contrast. This is the full dose, and this is the this is the 4th dose of contrast, but enhanced with artificial intelligence software, aiming to reach a time where we can use minimal amount of contrast, but with the use of artificial intelligence software, we can imitate the full dose. And God knows, maybe at one time, we can dispense the use of contrast at all and predict the post-contrast images without giving contrast based on the data analysis that is fed and stored in the computer. So you don't need to give contrast, but actually the artificial intelligence software may be able to give you a predictive image of how is this lesion going to enhance should you have given contrast. Now, this is actually from the daily practice. This is a WhatsApp message that was sent to one of my colleagues from a friend of his that is practicing in the States. Both senior years of residence. So this is within a software this is using a software being utilized in one of the American universities for residents to help them during on-calls. So he said, during my on-call, using a particular brand of artificial intelligence, these were misses or misinterpretations by the software. PE was called as a case was called as a PE, while it's actually a contrast mixing artifact. Similar thing, contrast mixing artifact was mistakenly interpreted as aortic dissection. A rib fracture was called, while it's actually, in reality, it's only degenerative changes. A subdural was called, while it's actually beam hardening artifact. What's even more alarming is the missing of information that is crucial to patient management, such as end-to-end anastomotic leak, cases of acute diverticulitis and epiploic appendicitis, vertebral artery dissection that was bilateral and missed, and small bowel obstruction. So these are areas that were missed, and these are areas where were mistakenly called in an on-call time in a busy emergency rotation. That all tells you that there is a place for the artificial intelligence. However, it has to be fine-tuned. It has to be trained, and it has to be gradually matured in order to become effective in helping to highlight abnormalities for the radiologist and give him an extra hand, but not replacing his own expertise and his own clinical judgment. So, is there a potential application? Of course, there's a potential application. There's a lot of administrative work that can be done by an efficient executive secretarial software and alleviate some of the unnecessary burden done by the radiologists, such as the screening of the radiology referrals, protocoling them, measuring the benefits versus the risks of the exam, minimizing the patient's risk, prioritizing reporting, and more administratively into the actually making the appointments and the booking, arranging patients' instructions, pre-procedures preparation, in the revenue cycle management, making the accurate coding for the procedure, reviewing the contracts, ensuring approvals, automation of invoicing, and keeping an eye over the financial support in terms of the invoice generation, collection, and reconciliation. This is all administrative work that can be done by the artificial intelligence. Within the clinical arena, it can help in standardizing the technical procedures in terms of the patient centering, scanning parameters, selecting the right protocoling, the 3D reconstruction, the volume measurements and analysis. Certainly can be done with efficiency by the artificial intelligence, and help in reporting by the proofreading, by the linguistic and grammar correction, by detecting and highlighting lesions that needs comparison, by giving you the preset measurements for lesion with percentage of progression and regression, etc., that will actually refine the report of the radiologist. WHO Working Group on Regulatory Consideration for Artificial Intelligence in Health has outlined certain challenges and cautiousness areas, particularly in the region of safety and privacy of patient data, ethical concerns for fair implementation and fair use of the artificial intelligence without being gender biased or race biased or ailments biased. The validation of artificial intelligence programs, algorithms, have to be meticulously looked into before being implemented clinically. The black box algorithm, where actually what it means is that the algorithm will give you a diagnosis, but will not give you an explanation how did it reach to this diagnosis. This has to be looked into to analyze the logic that these systems used in reaching the diagnosis. Certainly, the extensive use of artificial intelligence may use into expert de-skilling, the loss of skill in the human factor, whether may that be a radiographer or a radiologist. The trust of the population into the health system, the trust into the human factor of medicine has to be looked into this. And the medical legal dispute whether there's a patient that was misdiagnosed and resulted in a catastrophic outcome. Who is responsible for this? Is it the radiologist? Is it the software? Is it the hospital? Medical legal issues are of major importance in here. So as I said, the proliferation of the data, the extensive knowledge that is being provided, the medical errors that are prevalent, the shortage of the radiologists make place for certain implementation of artificial intelligence. However, artificial intelligence is and remain a clinical decision support system that assists radiologists in decision-making and should always be treated as such. Radiologists and radiographers should adapt their practice to the presence of artificial intelligence. Those who actually resist the change will fall out of the equation. Needless to say, companies that resisted digitization of image and remained persistent on using film imaging have fallen out of the equation, have vanished. Those who adapt their practice to the ever-improving technology will be able to continue to be a pivotal factor in the healthcare. So we as radiologists and radiographers should adapt our practice to the presence of artificial intelligence and use this capability to enhance our performance rather than resist its presence, and we may end losing the battle. I leave you with this joke where actually a computer is saying, I'm being sued for a misdiagnosis. What do I do now? And then the radiologist sitting back relaxed after the technology has taken over his work, telling him, sorry, buddy, it comes with the job. So when handing radiology over to artificial intelligence, does that sound appealing? Thank you very much for your attention, and I hope this shed some light on the utilization and future implementation of artificial intelligence in radiology and image analysis. Thank you.